Hello everyone, now let us discuss about 2023 ICD 10cm coding guidelines for chapter 16, which covers certain conditions originating in the perinatal period. So, the perinatal period is defined as before birth through the 28th day following the birth. It usually starts from 20 weeks to 28 weeks before the birth, and it will continue throughout the 28th day, that is up to 3 to 4 weeks of delivery of the birth. That period is considered as perinatal period. Now coming to the guidelines that we are going to discuss in this chapter are, first one is general perinatal rules, the next one is observation and evaluation of newborn for suspected conditions not found, coding additional perinatal diagnosis, premature and fetal growth retardation guidelines, low birth weight and immaturity status, guidelines regarding the bacterial sepsis of newborn, guidelines regarding stillbirth, and finally COVID-19 infection in the newborn. Now first coming to general perinatal rules. This is again subcategorized into use of chapter 16 codes, PDX for birth record, and guidelines regarding the use of codes from other chapters along with the codes of chapter 16, and use of chapter 16 codes after the perinatal period, birth process or community acquired conditions, and code or clinically significant conditions. These are the 6 subtopics under general perinatal rules. Now coming to the use of chapter 16 codes. Codes in this chapter, that is codes from chapter 16, are never to be used on the maternal record. And codes from chapter 15, the obstetric chapter, are never permitted on the newborn record. This is important. Chapter 16 codes are never to be used on maternal record, and chapter 15 codes should never be permitted on the newborn record. And chapter 16 codes may be used throughout the life of the patient if the condition is still present. Now coming to next guideline, principal diagnosis for birth record. Whenever we are coding the birth record, when coding the birth episode in a newborn record, assign a code from the category Z38. When we are coding the birth episode in a newborn record, we need to assign the code from the category Z38, live born infants, according to the place of birth and type of delivery. There are different codes for if the place of birth is hospital or other place. Similarly, type of delivery, whether it is vaginal or C-section, in that way. Whenever we are coding the birth episode on the newborn record, PDX should be Z38 series. And the code from Z38 is assigned only once to the newborn at the time of birth. If the newborn is transferred to another institution, a code from the category Z38 should not be used at the receiving hospital. It should be coded only once to the newborn at the time of birth. If the newborn is transferred from one hospital to another hospital, a code from the category Z38 should not be used at the second hospital. And code from category Z38 is used only on the newborn record, not on the mother's record. This is also important. Code from the category Z38 is used only on the newborn record, not on the mother's record. Now let us see examples. A pregnant woman delivering infant twins by cesarean section. So here the PDX would be from the category Z38. The code is Z38.31. Twin live born infants delivered by cesarean. Let us see one more example. A full-term baby was born 4 days ago, discharged, and then returned with jaundice. The baby is diagnosed with neonatal jaundice. Here, the PDX would be P59.9. A code from chapter 16, P59.9, neonatal jaundice unspecified. In the second case, we are not using a code from Z38 category because birth did not occur at this encounter. That is important. Z38 should be only coded once on the newborn record to indicate the birth episode. It should not be coded regularly. It should be coded only once, that too on the newborn record, not on the maternal record. Next guideline, use of codes from other chapters with codes from chapter 16. The codes from other chapters may be used with codes from chapter 16 if the codes from the other chapters provide more specific detail. And the codes for signs and symptoms may be assigned when a definitive diagnosis has not been established, and if the reason for encounter is a perinatal condition, code from the chapter 16 should be sequenced first. If the reason for encounter is a perinatal condition, code from chapter 16 should be sequenced first. And in general, you can use codes from other chapters if they provide more specific details. Coming to next guideline, use of chapter 16 codes after the perinatal period, that is after 28 days of birth. Should a condition originate in the perinatal period and continues throughout the life of the patient, the perinatal code should continue to be used regardless of the patient age. This is important point. If the condition is present throughout the life of the patient and that particular condition originates in the perinatal period, then the perinatal code should continue to be used regardless of the age of the patient. Now let us see an example. A newborn delivery at 25 weeks of gestation with birth weight of 610 grams. The appropriate codes would be P05.12. Newborn small for gestation age 500, the weight is in the range of 500 to 749 grams. And next P07.22. Extremely immaturity of newborn 24 to 26 weeks completed. And this code, that is newborn small for gestation age, low birth weight, can be present throughout the life of that particular patient. If this condition is responsible for any complication, you can code this irrespective of the age of the patient. Next, birth process or community acquired condition. If a newborn has a condition, it may be either due to birth process or it may be due to community acquired. And if the documentation does not indicate which it is, the default is to use birth process and code from chapter 16 should be used. If it is not clear whether a condition is congenital or community acquired, default should be congenital code in simple terms. If the condition is community acquired, a code from chapter 16 should not be assigned. If it is not clear whether it is community acquired or congenital, by default you need to code congenital code. And if the physician clearly documents it is community acquired, if the condition is community acquired, a code from chapter 16 should not be assigned in that case. Now coming to next guideline, code all significant condition. All clinically significant condition noted on a routine newborn examination should be coded. A condition is clinically significant if it requires first point clinical evaluation or therapeutic treatment or diagnostic procedure or extended length of hospital stay or increased nursing care and or monitoring or has implications for future health care needs. If a condition alters or requires any of the below points, then you can code all those clinically significant conditions on a routine newborn examination. Clinically significant indicates it need to require a clinical evaluation or therapeutic treatment or diagnostic procedure or extended length of hospital stay, increased nursing care or monitoring, or if that particular condition has implications for future health care need. So all conditions can be coded. Clinically significant conditions can be coded. One important note is the perinatal guidelines listed above are the same as the general coding guidelines for additional diagnosis, except for the final point. regarding the implications for future healthcare needs. Code should be assigned for conditions that have been specified by the provider as having implications for future healthcare needs. Because these conditions are regarding to the newborn, there is an additional point, implications for future healthcare need. That condition may require some sort of healthcare in the future. So even such kind of conditions can be coded, especially in case of newborn examinations, not all examinations. Now coming to next guideline, observation and evaluation of newborn for suspected condition not found. We are only suspecting the condition. The condition is not diagnosed and they are ruled out. They are given by the codes Z05 category. So this guideline, observation and evaluation of newborn for suspected conditions not found, is again subcategorized into first one, use of Z05 codes. Next is Z05 on other than birth record. How should you sequence the Z05 codes if it is not the birth record, and how you should sequence Z05 codes if it is a birth record. This we will discuss here. First, coming to use of Z05 codes. Assign a code from category Z05, observation and evaluation of newborn for suspected diseases and conditions ruled out, to identify those instances when a healthy newborn is healthy, he is not having any condition. A healthy newborn is evaluated for a suspected condition or disease that is determined after study not to be present. The healthy newborn is evaluated for a suspected condition or disease, and that particular determination, and it is determined after study that it is not present. That means the condition is ruled out. It is only suspected on a healthy newborn. In such case only you need to use Z05 codes. Do not assign a code from category Z05 when the patient is documented to have signs or symptoms. This is important. Do not use a code from category Z05 when the patient is documented to have signs or symptoms of a suspected problem. In such case, you need to code the sign or symptom, not Z05 codes. Second case, Z05 on other than birth record. A code from category Z05 may be assigned as PDX or first listed codes for readmissions or encounters when the codes from category Z38 code no longer applies. Whenever Z38 code is not coded, then you can use Z05 codes as PDX. And codes from the category Z05 are for use only on healthy newborns and infants for which no condition after study is found to be present. Observation codes. Observation and evaluation of suspected conditions ruled out should be used only on healthy newborns and infants for which no condition after study is found to be present. If there are any signs and symptoms, you need to code signs and symptoms only, not Z05 codes. And if it is not the birth record, Z05 code may be considered as PDX. And if it is a birth record, always remember Z38 will be the PDX. If it is a birth record, Z38 will be the PDX, irrespective of reason for visit. A code from the category Z05 is to be used as secondary code after the code from the category Z38 if it is a birth record. Live born infants according to the place and type of delivery. Now let us see an example. A full-term live birth child delivered vaginally. A full-term live birth child delivered vaginally is born to a chronic alcoholic mother and is placed in the neonatal intensive care unit for observation of possible alcohol-related problems and none found. Here after the study condition is not there, but this is a birth record. A full-term live birth child delivered vaginally is born to a chronic alcoholic mother and is placed in the neonatal intensive care unit. So the PDX would be Z38.00, single live born infant delivered vaginally, followed by Z05.8, observation and evaluation of newborn for other specified suspected conditions ruled out. Here Z05 code is given as secondary diagnosis and PDX would be Z38.00 because this is a birth record. Other than birth record, if the reason for encounter is observation and evaluation of any specified condition, then you can code Z05 codes as PDX. If it is not a birth record. If it is a birth record, PDX would be Z38 only. Codes from category Z38. Now next guideline, coding additional perinatal diagnosis. This is again subcategorized into two types, assigning codes for conditions that require treatment, and the next is codes for conditions specified as having implications for future healthcare needs. First coming to coding, assigning codes for conditions that require treatment. Assign codes for conditions that require treatment or further investigation, or they prolong the length of stay or require resource utilization. Any condition that requires treatment or further investigation, or if this prolongs the length of stay, or if it requires resource utilization, all these conditions can be additionally coded. Second category, codes for conditions specified as having implications for future healthcare needs. Assign codes for conditions that have been specified by the provider as having implications for future healthcare needs. And this guideline should not be used for adult patients. This is important. This guideline should not be used for adult patients. It should be used only for newborn. Now coming to guidelines regarding prematurity and fetal growth retardation. Providers utilize different criteria in determining the prematurity. A code for prematurity should not be assigned unless it is documented. This is important. Providers utilize different criteria in determining the prematurity, and a code for prematurity should not be assigned until it is documented. And assignment of codes in the category P05, disorders of newborn related to slow fetal growth and fetal malnutrition, and also categories P07, disorders of newborn related to short gestation and low birth weight, not elsewhere classified, should be based on the recorded birth weight and estimated gestational age. Codes from category P05. When both birth weight, this is also important guideline, when both birth weight and gestational age are available, two codes from the category P07 should be assigned, with the code for birth weight sequenced before the code for gestational age. Code for birth weight will take the precedence before the gestational age. When both birth weight and gestational age are available, two codes can be assigned from the category P05, and with the code for birth weight will take the sequence or precedence before the code for gestational age. And coming to low birth weight and immaturity status. Codes from the category P05, disorders of newborn related to short gestation and low birth weight not elsewhere classified, are for the use for a child or adult who was premature or has a low birth weight as a newborn, and this affects the patient current health status. P07 codes can be utilized also on the adult record if they affect the patient's current health status, immaturity status, to indicate the immaturity status. Let us see an example. Premature delivery by cesarean section. Mother was a cocaine user throughout the pregnancy. Birth weight of 1247 grams, 30 weeks gestation, baby with dehydration. So this is also a birth record, delivery by cesarean. So the first PDX would be Z38.01, newborn in hospital by cesarean delivery. Next, mother was a cocaine user, P04.41, newborn affected by cocaine use. Next, birth weight. Whenever birth weight and gestation, both codes are available, birth weight codes will take the precedence first, as we have discussed earlier in the guideline. So first code would be P07.14, birth weight in the range of 1000 to 2499 grams. Here the birth weight is 1247 grams. So this comes under this range. Followed by 30 weeks of gestation. For that, P07.34, premature delivery less than 37 weeks. This is based on gestation. And finally, newborn dehydration, P74.1, to indicate newborn dehydration. Here, treatment is not done for dehydration of the patient. Physician is just mentioning baby with dehydration, and this is a birth record. Since it is a birth record, Z38 series will take the precedence, followed by the codes from chapter 60. Now coming to bacterial sepsis of newborn, category P36 should be indicated. Whenever sepsis occurs in newborn, you need to code P36, category P36. Bacterial sepsis of newborn includes the congenital sepsis. If a perinate is documented as having sepsis without documentation of congenital or community acquired, the default is congenital and the code from category P36 should be assigned. And if P36, generally the P36 codes are combination codes which include the causal organism. So additional code from the category B95 or B96 should not be assigned. If P36 code does not include the causal organism, assign an additional code from category B96. And if applicable, use additional codes to identify severe sepsis and any associated organ dysfunction along with P36 codes. Now let us see two examples. Newborn presents with sepsis due to Escherichia coli. Here we have a combination for sepsis with Escherichia coli. So one code is sufficient. P36.4, sepsis of newborn due to Escherichia coli. Similarly, next example, newborn presents with sepsis due to Staphylococcus aureus. Here also we have a combination code. P36.2, sepsis of newborn due to Staphylococcus aureus. Whenever a combination code is not present, you can use additional code from the category B96 to indicate the causal organism. Stillbirth is coded by P95. Is only for the use in institutions that maintain records for stillbirths, and no other code should be used with P95. And code P95 should not be used on mother records. Three important guidelines. They are used only in the institutions which maintain separate stillbirth records, and no code should be used along with P95. And P95 should not be used on the mother's record. 3 points. Now coming to COVID infection, the final guideline, COVID-19 infection in the newborn. For newborn that test positive for COVID-19, assign the code U07.1 simply. And appropriate codes for associated manifestations in the neonates or newborns in the absence of documentation indicating a specific type of transmission. Whenever a newborn tests positive, you can directly code COVID code. And for newborn that tests positive for COVID-19 and the provider documents the condition was contracted in utero or during the birth process, then first you need to assign code from P38.8, code P35.8, code P35.8, other congenital viral diseases, followed by U07.1. Whenever, if the condition is contracted in utero or during the birth process. And when coding the birth episode in the newborn record, appropriate code from category Z38. This point we all know. Whenever coding the birth episode in the newborn record, appropriate code from the category Z38 should be assigned as PDX. Now there are two scenarios for COVID in newborn. When the newborn is diagnosed by COVID, then you can simply assign U07.1, that is COVID code. Second scenario, if the condition was contracted in utero or during the birth process, then you need to assign first P35.8, other congenital viral diseases, followed by U07.1. And when coding the birth episode in the newborn record, appropriate code from the category Z38 should be assigned as PDX. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.